What's up, what's up, how it's going? We are back at it again. We are back at it again. Playing Fortnite. So I'm just playing a game like, oh, let me just play a casual game before I set up everything. And then I ended up, I ended up dying quickly. Man, Fortnite is tough to learn, especially like as I got kind of to learn it. I'm trying to switch the keyboard. It's crazy. Why it's connecting forever? What's going on? What is going on? Connecting. Are you sure it's gonna? This is weird. Never did this before. What's going on? Why it's not working? Why it is not working? Come on. Are you serious? Is Fortnite down? Is Fortnite down? Epic Game public status is operations. Fortnite is working fine. So the problem is me. Let me see. Let me see if I can exit the game with the controller. Battery is low. Options. How can I close this game? We are updating Fortnite live. Technical difficulties, guys. What can I do? What can I do? Problem. This is so annoying. You know what? I'm gonna do something dangerous. I'm gonna do something dangerous. This is definitely not recommended. Okay. So I gonna I plugged and I'm gonna I unplugged my PS5 because I don't know otherwise how to fix this. Otherwise I don't know how to fix this. It was working fine like 5 minutes ago. And then I as I started streaming it stopped working. Are you kidding me, bro? Let's see. HDMI connected, okay. No signal. No HDMI. Bro. Come on. I think it is working. Nice. Okay. Whatever. Who cares? Who cares? Let's see. Fortnite. Is it gonna work? Please. Couldn't think yourself there with the conflict, bro. Okay. I think it is working. What's going on, bro? What's up, lulling? I'm trying to fix the game. It's not working. I'm trying to fix the game. Logging in. Are you serious, man? What's going on? Fortnite. I say Fortnite is operational, it's fine. Fortnite down. Mm. Mm. Guys, this is taking. Okay, yes, let's go. Guys, I have a couple of people watching here. If you new around here, my name is Dr. Fortnite. Hello? You are a doctor? Yes, I am doctor in Fortnite. Well, I'm a neurologist, like I work as a neurologist, but now I'm a doctor in Fortnite because I'm very good at Fortnite. Just kidding. Yes, kidding. This is why is this slow? Okay, I think it is working. I think we making some progress. We're making some progress. Oh, nice. I think it's working. Okay. Finally, bro. Downtime. Begun at 4 a.m. It's not 4 a.m. yet, so I don't know why it's giving me so much trouble to just start the game, bro. Here we go. I'm excited, honestly, to play. Hopefully, we will have I'm hoping we'll be able to play better than yesterday. So we'll see. Okay, let's get ready. Ooh. I'm ready. Let's go. Game found. If it didn't work, I'm gonna lose my mind. I'm gonna leave it. Okay, good. Now we're cooking. You're doing what are you doing, bro? Dancing? Bro, let us dance, bro. What are you doing? Dance. Hey! Open house, here we go. I'm gonna be very focused. Nice. Bro. Shotgun, yes. Take it. Nice. This is a shotgun? No, but I will take it too. Okay, that's better. Nice. Nice. Come on, here. Where are you? Where are you? No, I missed. I missed the first time. That was so stupid. Okay. Yes. shotguns. Maybe I don't need 2 shotguns. But how about that? Nice. Someone is here. They are downstairs. Oh no. No. Ah, man. I only think, oh, they are just they're acting like a robot. Let's just do whatever, and then I end up dying. Bruh. Play a game. Wow, how did they kill me? I'm so bad. Wow. How did they kill me? Bruh. I always wonder, how did these people kill me? Like, they barely know how to play. I need to practice more. We'll go here so we can practice. We'll go here so we can practice. Nice. Take this. Take this. Let's break this. Nice. Nice. I need a better gun than the one I'm carrying. Nice. Oh yes. Oh yes. Oh. Nice. Nice. Shotgun. I will take the shotgun. upstairs. No. That. And this. Oh, this light is my camera lighting is eFit football installed. Okay. Who cares? Who cares, bro? Let's go and fight these people, man. Oh, there's someone. Let's see them. This is a different one. I thought this is the same guy. Bruh. Damn. That's crazy. This light is so bright I can't even, see, man. Let me fix this. Okay, let's change this here. It's gonna work a little better. How about that? Still so bright. I think I just make it even. How about this? I think this is way comfortable, yeah. That was crazy bright color. Crazy bright light, I can't handle it, bro. I mean, the lighting was artistic and everything, but man, that was too bright, I can't even focus on the game. Let's be friends. Let's be friends. Let's be friends. Let's be friends, bro. People don't care about the joke, you know. Go, bro, what do you mean? Yeah, having squad. Although if you made the squad together, you may end up getting banned from the game, so don't do that, kids, okay? What's up? Bro! I thought you start. I thought you start fighting. That's funny. Hematopoiesis, you are a doctor? Yes, I am a doctor. I'm a neurologist. This is, I can't say this is straight face, but I'm not joking, bro. So I thought it would be funny to name myself Dr. Frogman. Bro, we have to play better. This, I'm trying to switch to keyboard, so it's really bad. I don't know how long this is gonna take until I'm able to play the same way I play on the controller. I mean, I wasn't the greatest controller player, but switching to keyboard is tough, bro. Pediatric patient present with dyspnea, dysphagia, dysphonia, and drooling. The patient is in acute distress, serotonin, and with inspirated stridor and auscultation. The patient is notably unvaccinated. What is the likely diagnosis? Bro, this is like step one question or something. It's been a while since I thought about anything that is not neurological. Bro, are you copying your step one questions here? Okay. No, bro. Oh no. This is definitely a robot. Okay, nice. Let me read this. Are you thinking this diphtheria for the first one? 43-year-old woman present to the ED after crashing her golf cart. She has past history of visual changes, color vision loss, and blurred vision. She reported an electric shock down her spine when her head is flexed. She has muscle weakness. What is the most likely diagnosis? What? The crashing her golf cart has nothing to do with the vignette. That's just are you thinking like demyelinating disease? Okay. Bro, no, don't kill me. No. I passed the step. What do you do? Are you resident? You already finished residency? Or are you still in mid school? MS3? Nice, man. How did you end up finding my channel? I'm curious. Just scrolling through Twitch. You will do your neuro rotation in 2 weeks? That's crazy. What a crazy coincidence. Just type doctor hoping to find something medical. Really? Like you just type doctor on Twitch or where? That's crazy actually. Well, it's not very medical here, you know. But I enjoy playing this game, so I was like, I might as well stream it, you know. No, I'm cooked. I'm cooked. There's too many people here. Bro, chill. Bro. Yeah, on search, man. I am right now, but the bundle Euro in with it. Oh, nice. Man, Romy and Euro. Do you want something challenging or something easy? To leave from here. Nice. Bro. I do what I'm doing. Bro, that's enough. If there's someone else shooting, yes, there's someone else shooting. I'm cooked. I'm cooked. Bro, I'm cooked. Don't kill me, bro. Bro, no. Please, let me live. No. I'm dead, bro. With your same questions, what is the other, what other diagnosis, like the one the lady with the, you said MS, what other diagnosis you think of? Other more rare diagnosis, if I told you she's from the Caribbean, what would you think of? Yeah. If she's, you know, MS is more common in white people, right? So if she's black, what would you think of? It could still be MS, but there are other stuff that you should think of. That's why I said I didn't say MS. That's why I said demyelinating disease, because there's other stuff. Okay. Where are we dropping? Yeah, Lyme can present with basically like anything. Yeah. GPS wouldn't like usually present more. GPS like it usually comes like once in a lifetime. It doesn't. If you have a relapse of GPS, you should probably think of something else. Very rarely, like almost impossible to have a relapse from GPS. But if something relapsing. Also the visual changes and stuff, it wouldn't usually fit with GPS. There are too many people here. I should leave. Too many people! Too many people, bro. Yeah, usually like there's a disease like entity called NMO, spectrum disorder. Like before we used to think it is part of MS, but now it's like this different entity. NMO spectrum disorders. You're probably gonna get something like this in the shop exam. And it's more common in black communities. Nice. Ooh. What is this? Void only mask. Ooh, nice. This is a new item. Rheumatic disease? I don't know if rheumatic disease will present the same way. That was the easy questions. If you didn't do neurology rotation, it is not an easy question. If you finish your what? If you finish your neuro rotation and you didn't hear of it, then you don't know about it at all. That's probably not good. Nice. Come here, bro. No, I'm so. No, he's chasing me, bro. Can you leave me, bro? Leave me alone. I don't have heals. Bro, stop. Leave me alone, bro. I will give you an easy one then. Yeah. What do you do for NMO? Yeah, basically like, you know, steroids. In the acute phase, you may give IVIG, plasma pheresis. So it's a little different. Usually with MS, you don't give IVIG and plasma pheresis, but with NMO, because it is antibodies. You could do plasma pheresis, remove the antibodies, or give IVIG so you can neutralize those antibodies. It's similar from MS. There is no specific antibodies that you know about in MS, but NMO we have very specific antibodies that we can target. Yeah, basically. But honestly, for a neurology rotation, like attending will probably be more happy if you worked on doing history and exam. They care more about the history and exam than your the knowledge. I mean, you still have to have know the basics, so you don't sound dumb, but they care a lot about, they know how to do the neurological exam, and they know how to take a good history, blah blah. Most of attending they care about this stuff. So it's probably a good idea to watch videos about the neurological exam, stuff like that. That's probably gonna help you in your rotation more than the theoretical knowledge. Bro, no. Okay. Nice. Someone? Oh, what do you do with this fish? That's crazy. Okay, nice. No. Neuro exam is good. Yeah, it takes practice. Now I can do a quick neuro exam in like 3 minutes, but like focus neuro exam. But like when I started, yeah, it takes me like 10 minutes to finish a neuro exam. What is the easy question? The easy question. Should I fight these people or should I skip? The easy question is, bro, no. This guy is not letting. No, where are you going? Escaping. The easy question is a 40-year-old, let's say 30-year-old male is present with unilateral headache, very severe headaches, lasting for up to 1 hour, associated with tearing from the eye, redness from the eyes, and he had this type of headache since he was 18-year-old. He was diagnosed with migraines by his primary care doctor, but he received multiple migraine medication and it didn't work. What is your diagnosis? Cluster headache, nice. Yeah, you are ready, bro. Just go for it. Go for it. Yeah, I didn't even finish the question. I didn't even finish the question, bro. Nice. Treatment in, yeah, so one of the, if they come to the emergency, like an easy treatment is oxygen. Even outpatient, you could give them oxygen, but you have to order it, get the machine going, etc. Bro, no. Yeah, I'm dead. Oxygen. You can actually give them like migraine medication. Some migraine medication they work for it, like sumatriptan, like one of the ones that works for cluster headaches too, like as needed. Steroids works. Of course, verapamil is the one that usually we start with too in the outpatient. Tupramate can work too, but like there are some medication that overlap between cluster and migraines. So sometimes patients they come with like kind of in the gray area. Not every patient gonna come like, oh, this is exactly cluster. Some patient will be like, oh, I have some migraine features and I have some cluster features. So what's going on? So I think about it. Maybe in the exam it's gonna always come like as very clear cut cases, but in practice sometimes it doesn't come as, no, I'm dead, yeah. I'm dead, I'm done. There's no way. If this guy didn't kill me, wow, that's crazy. This is crazy. Wow. This guy's an idiot, literally. I'm an idiot, but this guy is an idiot for sure. My health was 14, he wasn't able to kill me. So it's univaluable, and then we can combine those triptan, calcium corticosteroid, or just what works. Oh, no! Man, number 4, not bad. Oxygen. In the emergency, yeah, it's good to start with oxygen. If someone came in outpatient, I usually give them. It depends if it is episodic versus, like, so episodic, like kind of like sometimes just come only in like a certain month. Like let's say, oh, it come in February or March. Sometimes you can give them steroids only during that period. If it is more of a cluster headache that come all around the year, usually it's a good idea to give them verapamil to start with, and then give them sumatriptan as needed. That's the approach in outpatient usually for me. Yeah. So verapamil for prevention, and then sumatriptan to apport the headaches. So it really depends. But in the exam, they're probably gonna ask you about verapamil, oxygen, stuff like this, like the easy stuff. Nice. Verapamil is for prevention, yes. Triptans are for always. Triptan are always, almost always, to apport the headaches, migraines, for cluster. Triptans are always to apport the headaches. Verapamil, yes, for prevention. Steroids works either way, depending on how much you're giving. Very high doses of steroids can use it to apport the headaches. Like maintenance doses for a month or two, you can use it for prevention. For cluster headaches. Yeah. It's a little confusing, but migrants, yeah, migrants. You almost always start with giving. Yeah, again, if it is, let's say, if someone gets a migraine once a month or so, you probably can give them just prevention, like give them abortive medication, like give them triptan, like sumatriptan or something like that. If they're getting headaches like every day or every other day, especially if it is more than 15 per month, which classifies chronic migraines, you will lean toward giving them preventive medications, which like beta blockers, tricyclic antidepressant, topiramate, and sodium valproate. It's like the 4 common migraine medications. I'm assuming the physiology you're doing with cholesterol, why steroids work? I don't know why steroids work. Steroids work for everything. Literally for everything. Like anything you can think of, steroids could work. And honestly, I don't think there's anyone like know why steroids works. Hi Mason, how's it going? Just chatting about random stuff, medical stuff. So don't mind that. And we're playing some Fortnite. And there's a GDMT for migraines. That's so true. Yeah, but usually you don't combine them. You try something, didn't work. You try something else. Kind of trial and error. But yeah, like there's a specific. What about in pregnancy? Like, let's say if someone who has she's pregnant and then she has a migraine, but she's getting migraine like 20 migraines per month. What would you do? That's the question. Is basically what migraine medications are safe with pregnancy. Let them fight. Oh, he's coming for me. Where is he? Where is he? Where are you? Bro, no. That's enough. That's enough, bro. Definitely not giving file operator to permit. Yes. That's that is the key. Like absolutely not. Lavitalol. So the beta blocker that works better for all beta blocker can be helpful for migraine, but the one that works the best is propanolol. So propanolol is a safe option. It is a safe option, yes. Propanolol is one of the safe options, but still it is it still has little risk, but it's the safe option. There we go. Nice. Nice. I get theoretically if calcium channel well, you could also give mifepristone, but I'm pretty sure that don't make sense. Yeah, it's not a bad choice. I mean, if I'm giving beta blocker, I'll probably give propanolol, but labetalol, metoprolol, they do have some intermediate effects. Calcium channel blockers, it's off-label use. You could still like give verapamil or something, and for migraines, and they can work actually. But it's an off-label use, so there's no like very good, you know, it's not FDA approved or whatever. Yeah, steroids is probably not a good idea. Maybe in the end of pregnancy, it's not as, you know, but this like there's certain time that you don't wanna. Most of the time you don't wanna give steroids for a pregnant baby, but oh no. But you could give vitamins, riboflavin and where I'm going, bro? I have to look at the map, man. I have to pay more attention. I'm barely focusing. Honestly, I feel like I'm playing better when I'm not focused on the game because I tend to overthink. So it is what I was saying. Oh yeah, riboflavin and magnesium. This combination like proven also to be effective for migraine. It is the safest actually. But the safest is riboflavin and magnesium. Oh no, I'm dead. Yeah. No, yeah, I'm dead. Yeah, I'm dead. I'm dead. Riboflavin is B2. But coenzyme Q also works. There's a lag on the chat, so sometimes my messages come in pretty late after you say stuff. Yeah, I'm also like, it's difficult for me to look at the chat and look at the chat, like play and look at the chat at the same time. what is the nausea med that we give? Metoclopramide, because it also has some anti-migraine effect. Metoclopramide. B6. Hey, honestly, I'm not too sure about B6, but I honestly I wouldn't be surprised if it has some anti-migraine effect. You could look it up. But yeah, riboflavin, B2, and magnesium is the one that's. Okay. Oh, morning sickness. Yeah. Bro, you can tell how, you know, how long it's been since I went to med school. I don't remember that, bro. But if it helped with nausea, I guess you could give it. But if you are desperate, you could try it. I don't know if there's any study or anything that proven that B6 is helpful for migraine nausea. Come on, my bot. No. She's coming here. Bro. My aim sucks. This guy is definitely a bot. Anyone I can kill is a bot. Yes, B2 and magnesium for a pregnant lady is safe. It is safe. What's going on? I'm glitching. Is magnesium for preeclampsia prophylaxis for migraine? No. Like the magnesium you give for preeclampsia, it's usually IV magnesium. Like not like through an infusion. But for migraines, you like for prevention, you give tablets. Usually 400 milligrams. You could give 400 milligrams. Also riboflavin, 400 milligrams, and you could also give IV for acute treatment of migraine for the abort the migraine, IV magnesium. But I don't think preeclampsia and the indication for preeclampsia is different from that for migraine. Like it's different. I mean, if someone has eclampsia and preeclampsia and migraine at the same time and give them magnesium, it can help for both. But I don't think like that we give magnesium, My understanding, it helps to stabilize, Magnesium can help stabilize the nervous system. That's why we give it to preeclampsia. That's my understanding. What's going on? Why am I glitching so bad? Bro, what? Oh, interesting. Oh no, this guy is so aggressive. Listen him. Yes. Yeah. Yes, listen. Oh no, man. This guy is aggressive. Oh, nice. That was easier than expected. Because they always say headache was a huge red flag sign. Obviously, you need to have attention with it though. Yeah, like the headaches with preeclampsia is different. It's not really a migraine, because migraine by definition is a primary headache that doesn't have a cause. So if it is caused by another condition, it is not a migraine. What's up, bro? I'm just going in a circle, honestly. This is not very good. What are the bread and butter neuro workouts I should know? Like you mean a condition, or like what test we usually order? Like you should, like the common condition you can see in the hospital. So, like the most common, are you gonna do outpatient or inpatient or both, or you still don't know? Because it depends really. The stuff you see inpatient, outpatient is probably different than what you see inpatient a little bit. But if you are able to know which, if you are doing inpatient or outpatient or both, it'll be helpful. I'm assuming they're gonna have you do both. Oh no. This guy is crazy. No. Let's chill here and here. Like I want to go into the ED, so what is the most important for me to have masters? So if you wanna go to the like be go into emergency medicine like residency, I mean if you're gonna do emergency medicine residency, the most important one is probably stroke. Yeah, I'm dead. Yes, I'm dead. Stroke is the most important one if you wanna go to the emergency. Stroke, headache, seizures. Like the top thing you're gonna see in the emergency. Dizziness. Probably the top 4. So for a stroke, yeah, so let's say the patient, there's a patient who came to the emergency with a stroke that started, symptoms started 1 hour ago, came with right side weakness and aphasia. Within 1 hour, symptoms onset was 1 hour ago. So the first thing you do is you should activate the stroke code in the emergency, because this is a medical emergency. This is like the top neurological emergency, honestly. This like along with the status epilepticus. So activate stroke code. You do a neuro exam. So you wouldn't do like a full neuro exam. You should do something called NIH stroke scale. This is a keyword you should know before your stroke or your neuro rotation. NIH stroke scale. It's basically like, you could look it up on MDCal. It's basically like a structured like neuro exam. That's like takes like 2 minutes to perform. So it saves time. And you do that exam, and then you actually don't wait to do that exam. You do it as you take a quick history while you wheeling them to the CAT scan. Like you shouldn't stop getting them to the CAT scan to do that exam, but try to do it while preparing them to get the CAT scan, etc. And what's going on with this game today? I'm gonna leave. Yeah, you could do a CAT scan depending on the symptoms. If you're suspecting that the stroke is due to large vessel occlusion, like a big clot or so, you do a CT angiography. And then even if there is no hemorrhage, there is no bleed, and they are within the window for TPA or thrombolysis, you give them thrombolysis. And then you admit them to the hospital, observation, give them aspirin after you repeat the CAT scan, and then you try to figure out why they had a stroke. You get an echocardiogram and stuff like that to look if they have cardioembolic etiology. Because to prevent any other stroke, you need to know the cause of the stroke. But yeah, like in summary, like yes, CAT scan. If you need to, you can get the CT angiography. But look up inact stroke scale. It's important to know. I don't know why I'm having a lot of technical difficulties. Let's try reload. Okay. If it is past TPA window that you consult me with surgery or neuro IR, it depends if there's a clot, yes, you call neuro IR usually. Usually you don't need neurosurgery unless it is very big stroke and you expect them to have brain edema. Because if you have a very big stroke and after between day 3 and day 5 you would expect like brain edema. The same way if you had let's say if you had a very big cut in your arm, like after a couple of days it's gonna start swelling, right? So the same with the brain. So you consult neurosurgery if they have a very big stroke. So if they end up like having brain swallowing, they may need craniotomy where they open the skull and kind of ventilate the brain so it doesn't, herniate. Ooh, that was savage. Nice. Where you going, bro? Nice. Dead. Who is next? Oh no, I'm dead. How do I manage if it is hemorrhagic? Subdural hematoma in 76, call neurosurgery. It depends. So, yeah, subdural is a neurosurgical condition in general. But in general, the way to manage it is either it is big enough you have to evacuate it, or it is small that you just observe it. And of course, if they or an anticoagulation or an aspirin, etc., usually you need to stop it unless they have like something serious going on, like if they have a PE, active PE or something, you may, with the risk and benefits. But in general, yeah, you stop anticoagulation. But intraparenchymal hemorrhage. What is the most common cause of intraparenchymal hemorrhage? No, what I'm doing. I'm sorry, I missed one question. Could I run a duo with you? No, I'm playing. I am playing solo. Sorry, bro. Oh no. Hey, yes, let's go. Oh, nice. Let's collect this. Man, this is reload is insane, bro. The reload is insane. Are you family friendly? Yes, I am family friendly, bro. Why do you ask? You could play it in your TV. That is totally fine. Sorry, I missed the other questions. Say it again. Sorry, I missed it. You said intraventricular hemorrhage. Intraparenchymal hemorrhage. It could possibly like extend into the ventricles. Yes, intraparenchymal hemorrhage, like hemorrhage within the brain parenchyma, like the brain tissues itself, not like in the outside. Like, you know what I'm saying? Oh no. That's cool. How I'm still alive? Is it subdural, like bridging vein rupture? Subdural is yes. Subdural is the bridging veins. That's true. But it is either bridging vein rupture or perianeurysm rupture for subarachnoid. Yes. Well, it is more of an aneurysm for subarachnoid. Subarachnoid usually like an aneurysm, and subdural usually for a bridging vein. You could have some overlap, you know, but for the exam, you know. For the exam, that's true. And that's most cases like that, yes. But intraparenchymal hemorrhage is hypertensive hemorrhage. That's like totally different. That's not like the subarachnoid and the subdural. Technically, they are outside the brain, right? Like not the brain parenchyma itself, but inside the brain, like in the thalamus or in the brain stem, whatever. It is intraparenchymal hemorrhage. This is usually hypertensive. Smoking is another big risk factor. No. Okay. I don't know how I'm still alive, honestly. Like Loki, I have no idea. go, let's go, let's go, let's go. Yes! That was satisfying, bro. But I'm dead. I'm gonna die. No! This is crazy, bro. No. Ah, man. No, I'm saying aneurysm is subarachnoid, causes subarachnoid hemorrhage. But I'm saying subarachnoid hemorrhage, always think about aneurysm and subdural, always think bridging vein. I'm cooked. I'm cooked. Intraparenchymal hemorrhage think intraparenchymal think hypertension and smoking. It's like the biggest risk factors. Oh no, there's two people, man, on me. Ah, wow, these people, oh wow. Crazy. Ventricular hemorrhage, yeah. Ventricular hemorrhage, you could get it from subarachnoid hemorrhage for sure. Intraparenchymal hemorrhage also can extend to the ventricles. Subdurals, I don't know if subdurals can cause like intraventricular hemorrhage. Usually not, because it's like outside. But subarachnoid, yeah, can. I don't know why this game is glitching so much. The lenticular arteries, yes, absolutely. That is, that's what usually causes intraparenchymal hemorrhage, yes. Lenticular arteries. Management is really usually conservative. There's not much honestly to do. You should control the blood pressure. Usually keep it below 150. What is this guy? You know what? I'm just put this there. Oh, nice. Where is he? Where is he? Where are you? I see him. Oh! Wow! Wow! Bro, chill. Bro, chill, that is not that serious. Where is he? Oh no, the storm is coming. That's why he left. I'm going deeper into the storm, bro. What's going on here? Whatever, honestly, at this point, who cares? I think I'm gonna regret this. Wow, crazy. Okay, what? I kind of ignored the chat. For so stroke seems pretty straightforward. NI stroke scale CT. If thrombotic inventive TB, if not then consult vascular neuro, then medicine NI. If not, really consult neurosurgery. If yes, that sounds about right. Yes! Then I stroke scale, if you have time, you start it before the scan, and then if you couldn't finish it, you could finish it after the scan. So you don't really need to wait for the NI stroke scale. I forgot there's fall damage with this, bro. Bro, run for your life. Run for your life, literally. If I'm ready, what do I need to give in a main wire to stabilize patient with increasing ICP? First of all, you should rate the bed to 30 degrees. This is the first approach. And then if you need to, you can give stuff that decreases intracranial pressure, like hypertonic saline, stuff like that. If you're anticipating it purpose, it doesn't, not gonna work, you should do here, chemical Newton. Oh, I'm not going in the right direction. Some blues, bro. Okay, nice. You said bring page to 30 degrees. Hypertension 9. What else? Mannitol can be used. Mannitol. Anything that has high osmosis. Would the saline not spill out of the hemorrhagic vessel? Well, you're not giving it inside the brain directly. You're giving it IV, so it kind of, you know, goes to all the brain, so it doesn't necessarily just go in a certain area of the brain. Let's see. You didn't care about me. So why would I care about you if you didn't care about me? IV saline, mannitol, and position vision, yeah. That sounds about right. If there's anything with like the spider rate, I saw something like you make patient hypercapnic and acidic, it could restrict the cerebral vessels. Like hyperventilation. Yeah, I think they can use hyperventilation. Hyperventilation. But that's for someone who like, you know, intubated. Ah, bloody man, that's crazy. Oh, I forgot I can still play again. I forgot that this is a reload. Reload. Let's go. This is what I like about reload. It's like, oh, I died. I'm going back to the lobby and then I realize, oh, there's still continue playing. I made a mistake. It's okay. Oh, only 5 people left. Where are you going, bro? Come here. Oh no. No. task ready. Alright, man. 9 PM here. I gotta wake up tomorrow to see Demon Red. I appreciate you teaching though. I learned a lot. Alright, thanks, man. Good luck with your IM rotation, and hopefully you'll have fun with the Euro. So, yeah, have a good night. Feel free to stop by anytime. Actually, I think I should go back and play. I wanna go back and play with what's called PR. Let's see if they fixed it. Okay. Okay, this might be the last game. Unless I die in the first like 30 seconds. Okay. Oh no, bro! I'm back in reload. No, I don't want to play reload. Let's switch to Battle Royale. Okay, let's see if this is gonna be a better game. Let's see if this is gonna be a better game. Where are we landing, guys? Where are we landing? Let's land here. I feel like I'm gonna die. I'm gonna die quickly. I don't wanna die quickly. footsteps here, bro. I have too many footsteps here. Let's try this. Crazy. Bloody. Wow, what's going on here? What? Oh wow, he got me. Ah! My game is glitching. That's crazy. This game is glitching so bad. It's crazy. Okay. Okay. Let's go to Sandy Strip. Let's go to Sandy Strip. Nice. Okay. Let's Nice. Yes. Let's go. No, take this. Whew. This is an amazing loot. This is an amazing loot. go. Okay. Okay, where are we heading? Sorry, I got distracted. Okay. Why there is no one to shoot? I wanna shoot people. I wanna shoot people. Nice. Oh, well, I don't need this. Nice. Oh. Ah, man, he killed me. Yeah, that was not very smart. That was not very smart. Crazy. Alright, I'm gonna call it a day. Thank you guys for watching. I think I'm gonna see if I can rate someone else. Okay, I'm read the. I found my guy to read. Red. Rotten. Let's go. We're raiding people as usual. One viewer is ready to be rated. Two viewers are ready to be rated. Yes, we have two viewers. It is better than nothing. Alright guys, thank you for watching. It was all medical discussion, but it was also fun. I'm gonna see you guys tomorrow. Bye.